student in Ashram Medical College. Today he'll be presenting a surgery case. The moderator for today is Dr. Harish Dara sir. He's currently the head of Department for Surgical Oncology in HCG Cancer Center in Vizag. He has done his MBBS in Rangaraya Medical College, his PG in MNR Medical College, and his surgical oncology in Yashodhara Super Specialty Hospital in Hyderabad. Dr. Harish Dara is the co-founder of Cancer Conscious, which is a digital platform for cancer awareness and education. He's also an active member and teacher for oncology students. Now, handing over to Tilak sir to present his case.
A very good evening to the respected members of National Medicos Organization and the respected moderator of today, Dr. Harish sir, and all dear my members. I am Tilak from Ashram Medical College, and today I'll be taking part in this Ellapagada Subbarao, the clinical compass, which is a great opportunity for me, and I thank NMO for providing the opportunity.
20 people only.
Today's case presentation is on a thyroid case, and which came to our college OPD. It was a very interesting case. Initially, there was some other diagnosis, but later turned to be another one. And let's move on to the case presentation.
Tilak, 1 second.
Yes, sir.
Other people, please mute your phones. Hari,
intelligent.
Hari garu, please mute your microphones. Hari garu, please mute your. Thank you. Tilak, continue.
Yes, sir. So let's move on with the case. This is a thyroid case presentation. So these are the table of contents for today. We'll be discussing the patient details. Initially, first, that is socio-demographic details and the chief complaints, the present, past, family, and personal history, the general and systemic examination, provisional diagnosis and differential diagnosis, investigations, and the final diagnosis. So coming to the patient details, a 46-year-old patient named Mrs. Jangila Patan, a female from Pedapadu, a homemaker by occupation, came to the ENT OPD with the complaints of swelling in the anterior aspect of neck since 2 years and difficulty while swallowing since 1 month.
Dr. Tilak?
Yes, sir, yes, sir.
Is it okay if I interrupt you in between? So
yes, sir, yes, sure, sir. You could, sure, sir.
Yeah. The thing is,
Dr. Harish,
yes, sir.
You interrupt him as much as possible because his starting word also was wrong and he's not supposed to enter past the neck. Mano tarvata marchipotam danni. So if there is correct it then and there, no problem.
Okay. So can you show me the first slide, please?
Yes, sir.
The details of the patient, yes.
Yes, sir.
So I'll be discussing more about how you present in your examination so that it will be easier for the examiner and also for you. So when you're presenting a patient like case,
yes,
always discuss as if you are you should represent a patient as a person, not an object.
Okay.
So you should not say female. If I say 46 సంవత్సరాల స్త్రీలింగం జంగీల పఠాన్ వచ్చింది, that is not good, no, right? That is how you are presented in English. So a 46-year-old lady, who is a homemaker by occupation, named Jangila Patan, presented with so and so. That is how you should present. So it would be nice for the patient as well.
Yes, sir.
Okay, that is how you should present. Okay.
Yes.
Now, please present.
Yes, sir. 46-year-old
Lady.
46, yes, sir. A
Yes.
46-year-old lady.
If the patient is a male,
Yes,
you
sir.
should present a 46-year-old gentleman.
Okay, sir. Okay, sir.
Okay? Yeah.
Yes, sir. A 46-year-old lady, a homemaker by occupation, Mrs. Jangila Patan, came
Yes.
from Pedapadu, Eluru, came to the OPD with the chief complaint of swelling in the anterior aspect of neck since 2 years.
Swelling in the neck since 2 years.
Okay, sir. Yes.
Yeah.
Swelling in the
She
neck.
doesn't know. Yeah.
Yes, sir. Yes.
So the way, like when you are presenting, it should be more of an interaction between a doctor and another doctor. So
Okay.
how did she present? She presented with a swelling in the neck.
Yes, sir. Yes, sir.
Since when? So that should be more of a formal thing. Okay?
Okay, sir.
Yes.
A swelling in the neck since 2 years and difficulty while swallowing since 1 month. Shall I move on, sir?
Yeah, please do that. Please
Yes,
do.
sir. The patient was apparently normal 2 years ago when she noticed a swelling in the neck. It was insidious in onset and gradually progressive in nature. It was initially a small swelling, but increased in size gradually over time. As it was associated with pain while swallowing food, and there were no aggravating and relieving factors contributing to the symptoms.
Yeah, please go on.
Yes. She developed difficulty in swallowing since 1 month. She had difficulty in swallowing solids initially, when compared to liquids. The difficulty in swallowing was insidious in onset and gradually progressive. It was initially painless when the patient was swallowing food, but later it became painful swallowing food, that is solids initially, and later liquids. There were no aggravating and relieving factors for this above symptom.
So what are you implying actually with this history?
Actually, sir, there was a swelling in the neck which has developed insidiously, that is slowly progressing. It was initially a small pin-sized nodule, but it later developed into
Yeah, I understood the history, what you told. I'm asking
yes.
what are you implying? So what do you
It,
mean? Like what is the summary of whatever you have presented?
Sir,
There is a swelling in the neck.
Yes, sir.
Because it is slow growing, it could be benign. That's all, right?
Yes, sir. Yes, sir.
Yeah. So next symptom you have presented is difficulty in
Difficulty in
swallowing.
swallowing, sir. Yes.
So the swallowing was painless. Sorry, the difficult dysphagia is more for solids rather than liquids. That's what
Yes,
you
sir.
said.
Yes, sir. Yes, sir.
What does that imply? What does it mean?
Sir, it implies the severity of the progression, sir.
No. So for example, if you have said like the difficulty was initially for liquids rather than solids, what does that mean? Is there a difference?
Yes, sir. Yes, sir.
I'll tell you. See, if
Yes.
there is a difficulty in swallowing liquids rather than solids, means that problem is with neuromuscular coordination of the
Okay, sir.
upper digestive tract, like esophagus. For example, motility disorders. But
Okay.
if the difficulty is with more of solids, then it is a mechanical obstruction.
Okay, sir.
You understood? For
Yes.
example, in this case, the mechanical obstruction is probably because of thyroid compression. I don't know. You have to present, but I'm telling you, implication. Whenever you are presenting, you should
Yes.
imply something.
Yes, sir.
So you will get a question from your examiner during your final exam. What are you
Okay.
implying? What do you mean by this? So if there is a mechanical obstruction, either because of external compression by thyroid or a tumor or some foreign body, there is always difficulty in solids.
Yes.
Because people eat while sitting or standing, right? They won't
Yes.
eat while lying down. So because there is a mechanical obstruction, it is not complete obstruction. So there will be a small area, like small passage left. So because
Yes.
of gravity, the liquids might go down, but solids won't go down with gravity unless
Okay,
otherwise
sir.
there is a mechanical obstruction. So whenever
Okay.
you say there is a difficulty in with the solids rather than liquids, it implies that it is mechanical obstruction.
Obstruction. Okay, sir.
You got it?
Yes, sir. Yes, sir.
Yeah. Next.
Uh, weight changes. There is history of gradual weight gain since 2 years till the last 1 month, and there was sudden history of weight loss since 1 month of about 10 kgs. Negative history. There is no history of heat or cold intolerance. There is also no history of excessive sweating. There is no history of hoarseness of voice. There is no history of ear and nose complaints. And there is also no history of hair fall, sir.
Yeah, Dr. Tilak,
Yes,
I'll
sir.
simplify this.
Yes.
So you said there is a gradual weight gain and
Yes, sir.
suddenly there is a significant weight loss.
Yes, sir. Yes, sir.
What does that imply?
Sir, it is some benign to malignant transformation. It might have been like that, sir.
Good, very good, very good. So you are implying that it is a malignant tumor. So next thing you should tell is about whether there are features of malignancy or not. You understood?
Yes, sir. Yes, sir. Yes, sir.
Yeah. So what are the features of malignant thyroid lesion?
Sir, it can be like there is no carotid pulsation, and there will also be
But those
stridor.
are examination findings,
Okay, sir. Okay.
right?
Yes, sir.
History.
Yes,
I'm
sir.
asking about history. So, for example, if there is a thyroid malignancy, what are the symptoms the patient present with?
Sir, difficulty in swallowing, sir.
Yes, good.
Difficulty and shortness of breath, sir.
Very good. Shortness of breath, probably because of metastasis in the lung. Yes.
Yes, sir. And also
And
it can be also due to compression of trachea, sir.
so, what will the patient present with?
Stridor, sir.
Stridor. Yes, not wheeze.
Yes, sir.
So, what are the other symptoms?
Right.
In a malignancy?
There'll also be weight loss, sir. Since
You
it is a
already said.
malignancy, it'll be a weight loss,
You,
sir.
you already said. See, presenting a malignant case is very. First, you should present the history with local infiltration, then metastatic problems. Okay.
Yes, sir.
So, what are the structures in around thyroid lesion, thyroid region?
Uh,
One is
yes, sir.
trachea, you already told.
Yes, sir. There'll also
The other
be
is esophagus, sorry, pharynx and esophagus.
yes, sir.
That you have
There'll
already
also
told is
be
very.
the
There is an
vessels,
important
great.
structure. No, there is an important structure near thyroid gland, which actually people generally speak out while doing surgery. What is that important structure?
It is the recurrent laryngeal nerve and external
Yes.
laryngeal
So
nerve.
yes, what happens if there is an infiltration of recurrent laryngeal nerve?
There'll be vocal cord palsy, sir.
So vocal cord palsy, what is the symptom?
Um, it'll be like
Hoarseness of voice.
dysphonia, sir. Yes, sir.
Hoarseness of voice.
Yes.
So you should tell the word. That's what I wanted this one. Whether there is
Okay.
history of hoarseness of voice or not.
No, sir. There's
So
no history.
what your negative history was telling, you are implying that there are no features of hyper or hypothyroidism, right?
Yes, sir. Yes, sir.
You can simply say that there is no history contributing because you are presenting with a doctor, right?
Yes, sir. Yes, sir.
So you can simply say that there is no history contributing, suggesting of hypo or hyperthyroidism.
Yes.
So then the examiner might ask you, what are the features of hyperthyroidism? What are the features of hypothyroidism? So these are the questions you might expect. You don't need to say because the examiner might get bored if you present
Yes,
all
sir.
no history of all those things. Okay.
Okay,
Yeah.
sir. Yes.
Go on.
Past history. There is no significant
Was
similar
there any
complaint.
history of hoarseness of voice?
No, sir. No, sir.
Yeah. So there is no you with this present history. What is the summary of your present history?
There might be there would have been a solitary nodule in thyroid, which might have progressed to a multiple nodular goiter, sir.
You said there is significant weight loss, no?
Yes, sir.
So you're implying that there is a transformation into malignancy, right?
Yes, sir. Initially, the doctors too thought that, sir, in our hospital,
Yeah.
but it is not the case, sir.
No. With the present history, I'm telling.
Yes, sir. Yes, sir. Yes,
Your
sir.
diagnosis might change with the next thing. I'm just
Yes,
asking
sir.
about present history summary.
Yes, sir. Yes, sir.
So there is a lesion in the thyroid, which was since 2 years, which was gradually progressing and sudden increase in size and significant weight loss. No history
Yes,
of
sir.
local infiltration or hypoparathyroidism.
Yes, sir.
This is your summary.
Yes, sir.
Yeah, next.
Yes. Past history. There are no significant similar complaints in the past before the onset of symptoms. There is history of hysterectomy, which was done 17 years ago due to a submucous leiomyoma. There is no
Why, man?
history.
Why unnecessary digging your grave? What is the point of telling all this? There is history of hysterectomy for
Okay, sir.
fibroid uterus. That's all. What is
Okay, sir.
if you ask if you tell what I'll ask what is submucous what you tell submucous leiomyoma? What does that mean?
That is in the endometrial aspects, a bit beneath the endometrium. If the fibroid is present, it is called as
Don't say
submucous.
unnecessary things which
Yes,
you
sir.
don't
Yes,
know.
sir. Sure, sir.
Okay.
One,
Yes, sir.
one
Yes,
Yeah.
sir.
minute,
Sure, sir.
Harish here. Tilak,
Yes, sir.
tell me the classification of leiomyomas and submucous leiomyomas.
According to FIGO classification, there are 7 types of leiomyoma, sir. And based on the structural location, there are 3 types. So that is submucosal, uh, interstitial, and subserosal, sir. And can be sometimes called pedunculated fibroadenomas, sir.
Histopathology, histopathology,
Fibroids, not fibroadenoma.
Sorry, sir. Sorry, sir. Yes.
histopathology.
Histopathology, there'll be a layer of smooth muscle layers, sir, and it'll be like in a world pattern, sir.
What is the special cell in that?
Sir,
స్పెషల్ సెల్ ఏముంటుంది దానిలో? అందుకనే
one, yes,
లియోమయోమా పేషెంట్ చెప్పింది నీకు చెప్పలేదు కదా,
yes, sir, yes.
గర్భసంచి చెప్పింది. సో హిస్టరీని ఎంత సింపుల్ గా చెప్తే మీరు
Okay, sir.
ప్రెజెంటేషన్ స్మూత్ గా అవుతుంది. నువ్వు హిస్టరీలో దొరికావు అనుకో, దొరికిపోతావు. అది దట్స్ వాట్ సర్వీస్ ట్రై టు టెల్ యూ.
Okay, sir. Okay.
Unnecessary things avoid చేసేయండి. So,
Okay, sir. Okay, sir.
was there any similar complaint in the past? No.
No, sir.
That's the post. Yeah. So there was history of surgery. Why do you ask for
Yes.
history of any surgeries and all? What is the point of asking?
If there is a malignant lesion, there can be secondaries in the thyroid or something.
Which malignancies actually has thyroid mets? That will be a very good case report actually.
So there could be
See,
so there could be some
always
bone
remember.
Yes, sir.
Always remember, common things are commonly correct. Rare things are rarely correct.
Yes.
This was what my boss used to tell. So we ask for history of surgery because if I'm going to do surgery for this case, will there be any problem? Was there any problem while doing surgery? Nothing. So this is simple.
Okay.
Or any surgery related pertaining to this? No. So history of hysterectomy 17 years ago for some benign condition. Or if you want, people can say fibroid uterus. Okay.
Okay.
Yeah. Go on.
There's also no history of other comorbidities like diabetes and hypertension. There is no history of asthma, tuberculosis, or any cardiac diseases. There is also no history of blood transfusion, chemo, or radiotherapies taken in the past.
If there is no history of malignancy, why would I ask for chemo and radiotherapy? Okay. Yeah. Next.
Personal history. The patient had normal appetite. Yes. The patient had the patient had normal normal appetite, and she takes a mixed diet, and there is regular bowel and bladder movements. There are no known allergies to the patient. There is no history of habits like alcohol or smoking or tobacco chewing. There is no history of drug abuse, and there is no history of betel nut chewing. The short note on menstrual and obstetric history.
See, you can simply say there is no history of tobacco intake in any form.
Yes.
That's an easier word. You don't have to say smoking, tobacco chewing, betel nut chewing, and all those things. Okay.
Okay.
That will be a simpler way to say. Yeah.
Yes. Menstrual history. The age of menarche was 14 years, and the age of menopause was 45 years. Obstetric history. She had 3 live children.
Okay. Why am I laughing?
Actually, sir, she's G0, sir, gravida 0, parity 3, and 3 live children, sir.
Okay. Yeah. You just your Tamilian Telugu?
Tamil, sir, yes.
Just translate the word three. He had three live children in Tamil in your language. That would be very funny, man. Okay,
மூன்று
next.
உயிருள்ள குழந்தைகள், sir.
Yeah, next family history.
Family history. There is no significant family history noted. There is also no history of comorbidities in the family.
So,
And there
what
is
is
no
the significant family history associated with thyroid malignancies?
For example, of goiter, so we can take like in the particular region, the goiter can be more evident, sir.
Okay, good.
And there can also be some thyroid malignancies which can be running in genetically in the family, sir.
What kind of thyroid malignancy actually runs in family?
Medullary carcinomas.
Very good, very good. So, what are the associated cancers associated with medullary carcinoma?
They can be pancreatic cancers. It is mostly associated with men to a malignancies, sir.
Very good, very good. So, what is Menn syndrome?
Um,
Don't just take.
yes,
I'm just asking. If you don't know, tell me. That's all.
yes, I don't know about it, sir.
So, it's a multiple endocrine neoplasias where usually medullary carcinoma. Whenever there is a medullary carcinoma, you should always search for pheochromocytomas also.
Okay.
So, because some patients will have subclinical pheochromocytomas present with medullary carcinomas. So, when you post the case for surgery, so
Yes.
people might overlook pheochromocytoma.
Okay.
So, during surgery, the BP will shoot up and patient may die on the table also. So, always whenever you are opting for surgery for pheochromocytoma, always do a screening test for pheo also. That's I
Yes.
just wanted to tell you. Okay.
Yes.
Next. The papillary carcinomas also runs in families, not only medullary.
Okay, sir.
There are certain varieties of papillary carcinomas that run in families, but rare.
Okay.
So,
could I continue, sir?
yeah, please.
Yes, sir.
Do that.
Head to toe examination. A 46-year-old lady, moderately built and nourished, conscious, coherent, and cooperative. She had a body weight of, she has a current body weight of 65 kgs, and her height is 160 centimeters, and her BMI is 25.4 kg per meter square,
Why do
which
you want
indicate,
BMI? Why did you
sir,
do this? BMI and all?
sir, it's a regular checkup, sir.
No, it's not regular, man. There is a reason for why do we do those things. Everything you say has some meaning. Why actually do you want to check BMI for a malignancy suspecting case?
Uh,
I'll tell you. See,
yes,
most often the chemo drugs which we give, not for
yes,
thyroid, but most often all malignancies. So, like for all the drugs we give actually based on body weight, right? For
yes.
chemo, most often those are for based on body surface area.
Okay, sir.
So for body surface area, you need to have height and weight of the body.
Okay, sir.
Okay. Yeah.
There's no history of alopecia. There is no history of pallor. There is also no
Alopecia.
history of, sir.
Is it why alopecia?
Sir, in both hyper and hypothyroidism, there can be hair loss, sir. So,
Okay.
we
Okay.
asked about
That's
it.
general examination. No, you're saying
Yes,
that is okay. Fine.
yes. There's also no history of icterus. There's also no dental caries or stains. There's also no clubbing, no history of cyanosis, no lymphadenopathy, no edema, and no eye signs.
What lymphadenopathy? What do you mean by lymphadenopathy? Where did you check?
Sir?
You said no lymphadenopathy, right?
Yes, sir.
What do you mean by lymphadenopathy? Which lymph nodes did you check?
Sir, cervical group of lymph nodes, sir.
This is general examination, right?
Yes, sir. Yes, sir. Yes.
So you should be saying no generalized lymphadenopathy.
Okay, sir. Yes.
The lymph nodes you are telling about cervical nodes, that is local examination. What is
Okay.
generalized lymphadenopathy?
Throughout the body, sir.
There is a specific definition for generalized lymphadenopathy.
Not sure.
Yeah. When more than two non-consecutive group of lymph nodes are enlarged, it is called generalized lymphadenopathy.
Okay.
You understand? What do you
Yes,
mean
sir.
by non-consecutive? For example, there
Yes.
is inguinal nodes and also pelvic nodes. There are two groups of lymph nodes, right? But it is
Yes,
not
sir.
generalized. It is
Yes.
localized only. But if there is inguinal nodes, axillary nodes, that is non-consecutive.
Okay.
That will be called as generalized lymphadenopathy. So in
Okay.
general examination, you should be speaking about generalized lymphadenopathy, not local lymph nodes.
Okay.
Okay? Yeah. Can proceed.
Yes. The vitals. The pulse rate is 85 beats per minute, and there is a regular rhythm, normal volume and character. It is of there is no radiofemoral delay, and other pulses, peripheral pulses are palpable.
Is,
Respiratory rate.
is pulse rate important in this case?
Um, no, sir.
In this thyroid case, general for
Uh,
thyroid.
Carotid
When,
pulse.
no,
We check.
pulse rate is important, right? For hyperthyroidism.
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
When is the ideal time to check pulse rate
Sir,
in hyperthyroidism?
sir,
When is
could
the
you
ideal
please?
time? When is the ideal time you should check for pulse in case of hyperthyroidism?
Mornings.
Sleeping pulse rate when the patient is
Okay.
sleeping. Yeah.
Mm,
Okay.
okay. And the respiratory rate is around 14 breaths per minute, and it's of thoraco-abdominal. And the temperature is 98.6 degree Fahrenheit. And the blood pressure recording is 130 systolic and 70 diastolic millimeters of mercury in right arm supine positions.
Okay.
Systemic examination.
Any
Uh,
issues with systemic examination?
no, sir.
Next, proceed, please.
Yes. Inspection. Uh, a single round to oval shaped swelling is present in front of the neck in mid-thyroid region on left side, extending from thyroid cartilage up to 5 centimeter above the suprasternal notch, with the dimension of around 4 centimeter length by 3 centimeters breadth.
Okay.
The swelling moves with deglutition, and the lower margin of the swelling can be visualized on deglutition. The swelling doesn't move on tongue protrusions. There is no venous prominence over the swelling without any visible pulsations. There is no signs of sympathetic trunk involvement. That is called as Horner's syndrome.
Why
It
do
is
you want to
not.
tell about why like is it a part of examination? Horner
Uh,
syndrome.
no, sir. Actually, I saw in DAS and I referred it, sir.
Okay. Unnecessary things, man. Like you'll
Okay,
be
sir.
yeah.
Yes.
Please go, proceed.
There
What
is
is
no
Horner
red.
syndrome?
Sir. Sympathetic in trunk involvement, we can see Horner's syndrome.
So what happens in Horner syndrome? What are the features?
Uh, Not sure, sir.
It's okay. It's okay. Go ahead.
Yeah, proceed.
Yes. There is no redness, scars or sinuses seen on the swellings.
Okay. So yeah.
Yes.
So inspection, what do you think? How is like you said
Uh,
there is no swelling does not move on tongue protrusion. What does that mean?
it excludes the thyroglossal cyst things.
Good. Why why does thyroglossal cyst move with tongue protrusion?
Because according to embryology, the thyroglossal cyst arises from the foramen cecum of the tongue, sir.
Okay, good.
Yes.
Uh yeah,
Yes.
proceed.
Yes. Palpation. All the inspectory findings are confirmed on palpation. The temperature over the swelling is normal and the swelling is non-tender. The swelling has a smooth surface with well-defined margins. It has a soft consistency and with no pulsations or thrills. The swelling is mobile in vertical and horizontal directions, and its lower margin is palpated. The swelling is not fixed to the overlying skins. Trachea is in central position, and Coccus test. The Coccus test is a test which is used for long-standing multinodular goiters or any anaplastic carcinomas, in which the tracheal rings get keratomalized, and there can be stridor when we press the nodule, and that's called as Coccus test. And this is negative
What?
in this case,
Yeah.
sir.
Yeah, fine. Good.
Yes, and this is the negative in this case of thyroid in this swelling, and carotid pulsations are palpated bilaterally at normal site, and hence Berry sign is negative. Berry sign is like when the nodule displaces when the nodule engulfs the thyroid and engulfs the carotid artery. It causes absence of carotid pulsations. So it is not present in this case, so it's a negative sign, sir. Pemberton sign is negative as there is no engorgement of neck veins. Pemberton sign is when we have to raise the hands of the patient above the arm level in touching the ear lobes. And if we do so, there will be engorgement of neck veins in uh, enlarged goiter cases, and it is not present in this case. And the lymph
So
nodes of
I
the
appreciate you read all the signs, but the thing is, you have to speak all those in cases of large thyroids. So you
okay,
like if very for a small thyroid lesion, you don't expect Pemberton sign to be positive. You don't expect Cocker sign to be positive.
okay,
You understand, right?
yes,
You, I, yeah, understood. You read. That's a good thing, but it's not necessary for this case actually. Okay,
okay, sir, okay.
yeah, nice. Lymph nodes.
Percussion
What about lymph nodes?
lymph nodes are also not palpable, sir.
Which lymph nodes did you check?
The submental, submandibular, jugulodigastric,
The most
homohyoid,
common.
and
Sorry.
sir,
Wait.
yes,
What are the lymph nodes that are involved in case of thyroid lesions?
pretracheal and paratracheal group of lymph nodes,
Okay,
and the mediastinal group of lymph nodes, sir.
mediastinal. So see, there is certain one. There is a classification for neck nodes, right? Level one,
Yes,
two,
sir.
three, and
Yes,
5.
sir.
Oh,
Yes,
6, 7. How many levels are there?
7, sir, 7.
So please tell me what are those? Level 1 is 1A,
Uh,
1B.
yes, sir. 1A is submental and 1B is submandibular, sir.
Very
Uh,
good.
2 is um, uh,
Upper
uh,
jugular, middle jugular, lower jugular.
yes, sir.
2,
And
3, 4.
yes, and
5 is
five is
posterior triangle of neck
yes, yes, sir.
behind
And
the
six
sternum
is
masseter.
yes, sir.
6 is
Pretracheal and paratracheal group of lymph nodes, sir. And the
central
seventh
compartment.
one, yes, sir.
It is
And the
mediastinal. Now tell me the levels of lymph nodes that are involved in thyroid lesions.
pretracheal and paratracheal are
That
involved,
is
sir.
level 6.
Yes, sir.
Yeah. Then where did they
Uh,
go of level 6?
they go
Did it go to
into
mediastinum or there are certain areas in the neck where you.
not sure, sir.
So the most first draining group of lymph nodes is level 6. That is between two carotids, laterally, superiorly, uh, hyoid bone, inferiorly, suprasternal notch.
Okay,
That
sir.
area is called level 6. These are called central compartment nodes.
Okay, sir.
These are the first nodes that are involved. Next is level 2, 3, 4.
Okay, sir.
Those are lateral compartment of neck. Then
Okay,
they go to level 5. In advanced cases, they will go to level 7. Level 1A and 1B are rarely involved.
okay, sir.
So when I asked what are the lymph nodes, you said directly submental, which is very, very rare.
Okay,
So Dr. Uday Shankar has asked me what are the different levels of nodes. So level 1A is submental. Level 1B is submandibular. So is my video seen? Am I
Yes,
visible?
sir. Yes, sir.
So level 1A is this region, submental, between two bellies of anterior digastric muscles. This is level 1A.
Yes,
1B is and between anterior belly of digastric and posterior belly of digastric. That is submandibular.
yes,
Level 2 is upper jugular.
yes,
Level 3 is middle jugular. Level 4 is lower jugular.
yes,
1A, 1B, 2, 3, 4.
yes,
Am I visible
yes,
in
sir.
video? I don't
Yes,
know whether. Level 5 is posterior triangle.
yes,
This is behind the sternomastoid.
yes,
So 1A, 1B, 2, 3, 4. This is 5.
yes,
6 is between two carotids. Between two carotids, below the hyoid bone and above suprasternal. This area is called central nodes.
yes.
Level 7 is mediastinal.
Okay,
Okay. These are the lymph node stations in the neck.
okay,
So for thyroid, the first group of lymph nodes that are involved is level 6. Then they go to 2, 3, 4. So usually for thyroid lesions, what we do is with thyroidectomy, we do a central compartment lymph node dissection. If the disease is advanced, if the nodes are involved, I'll tell you in the discussion. We go do lateral
okay,
compartment like 2, 3, 4 also.
okay.
Okay. Yeah. Next, please.
Percussion and auscultation, these findings are negative, sir. The percussion is done for the retrosternal goiter, sir, which is on the manubrium sternum, which is negative, sir. And the
Okay.
auscultation, it is also negative, sir, which is positive in cases of primary toxicosis.
Yes.
Uh, examination for toxic signs, it is absent in the patient, sir.
Okay.
There are no tremors in the hands and tongue. The patient doesn't have any proximal muscle
No,
wasting,
no
sir.
symptoms suggestive of hyper or hyper.
Yes,
No
sir. There are
findings.
also no
Yeah.
signs, sir. Yeah, eye
Yes.
signs. Yes. The provisional diagnosis, sir. Uh,
Yes.
the provisional diagnosis is probably a case of solitary thyroid nodules, sir.
Okay.
Differential diagnosis could be colloid nodule, chronic thyroiditis, or neoplastic conditions.
So you are implying that it is as if it's a malignant, right? Why did you keep your thyroid neoplastic is last? Your history was suggestive of malignancy, right?
Yes, sir, but there are no signs of infiltration, sir. That's
If it is
why.
early lesion, there won't be any infiltration and all.
Okay, sir. Okay, sir.
Usually thyroid malignancies are detected early.
Okay, sir.
Why?
Um,
Because there is a nodule seen in the neck, like everybody can see.
okay, sir. Okay.
So they usually present early. If it is a small thyroid nodule, they just present. They come to the hospital if the patient is a bit educated.
Okay, sir.
Yeah. So
Yes.
what do you do?
Uh,
What do you
we'll
want to do?
send the patient for investigations, sir.
Yeah, yeah, that's what. How do you investigate the patient?
Yes, sir. Initially, we'll do a thyroid profile, sir, for the patient.
Yes.
We'll check the levels of TSH initially, sir, because TSH is the main indicator which we check for. And later we also do a T3 and T4 also, sir. And if
Yeah,
possible,
thyroid profile means T3 and T4 TSH. Okay, fine.
yes, sir.
Yeah.
Based on the variations of the T3 and T4 and TSH, we could diagnose it as like a hyper or hypothyroidism, sir.
What
And
is the like? Did you
uh,
check for this case?
yes, sir. The patient is euthyroid, sir.
Okay, euthyroid. Next, what the other investigation you do?
We could do ultrasound, sir. Ultrasound
We
next,
should,
sir.
we should do, yeah, we should do ultrasound. So what are the
Yes, sir.
findings in ultrasound?
Yes, sir. In the left lobe of the thyroid, there is the solitary nodule is present, sir. And in the right lobe of thyroid, there are multiple small nodules present in the thyroid, sir, which was detected only on the ultrasound, sir.
Okay.
Um,
Do you
and
have
late,
ultrasound report with you?
no, sir. I have the write-up of the ultrasound records. Yes.
So what is TIRADS? TIRADS.
That is the thyroid imaging proposed by the Radiological Society, sir. Um, that is thyroid imaging reporting and data systems, sir.
Yes. Was it reported for this case?
Um, no, sir, I couldn't gather those documents. It was not available in the hospitals.
So see,
Yes.
is it possible for a person to suspect malignancy in case of by seeing ultrasound?
Yes, sir. According to thyroid, TIRADS, we could tell that TIRADS 1 and 2 is like more of like a benign lesion, and more than 3, we could suspect a malignant lesions.
Okay. What are the features you see in ultrasound where you should suspect malignancy?
Uh, like the it is like an irregular mass, sir,
Okay.
and it involves the underlying tissues, in underlying structures.
So extracapsular extension. Okay, that you can see in ultrasound. Good. Next,
Um,
if nodes are involved, is it malignant or not?
yes, sir, malignants.
Yes. Then there are certain like if you have this report, like just a minute. That is mentioned. So they'll mention the dimensions, whether the round or oval, those things. Based on that, also we can actually suspect. Okay.
Okay, sir.
Yeah. Next, what are the investigation?
Actually, the investigation basic done where CBC was done, sir, and
Was there any
which is
abnormal those things?
no, sir, no, sir, no, there was not any abnormalities.
Okay.
The peripheral smear is also normal,
Okay,
sir.
those are done.
Yes. The thyroid profile is also normal, sir.
Euthyroid. Euthyroid
Euthyroid
ultrasound.
patient.
Next.
Yes.
Next investigation.
The serum calcium was taken, sir, to suspect any parathyroid things. So it was taken, sir, serum calcium.
Is it mandatory to check serum calcium for a? It's not mandatory actually. What is
Okay,
the
sir.
most important investigation you should have done now? You have done an
Video
ultrasound.
laryngoscopy, sir, or indirect laryngoscopy.
Before that also you do one more investigation, which is very, very important. FNAC have you done? Cytology?
Yes, sir. Yes, sir. FNSC is done.
Yeah, yes.
Yes.
So whenever there is
FNSC.
a thyroid
Yes.
case
Yes.
that comes to you, 3 investigations are mandatory.
Yes, sir.
One is radiology, ultrasound.
Yes. Mm.
Second is thyroid profile. Third is FNAC.
Okay, sir.
This is standard.
Yes.
So what are the findings in FNAC?
There was a hemorrhagic background, sir, and the smear showed follicular epithelial cells, sir, and there was a slight oncocytic change, sir, and a few macrophages were also seen in that smear, sir.
So it's a not benign,
Yes, sir.
nodular goiter with cystic degeneration. Okay. Okay. What is the next step?
And the final diagnosis, as per the thing, was multinodular goiter, and the plan of treatment was total thyroidectomy, sir.
Why?
Sir, multinodular goiter has recurrence rate, and it also has complications like secondary thyrotoxicosis and risk of developing follicular carcinoma. And
Okay. So usually if there is a thyroid lesion, unless otherwise the indications for a benign thyroidectomies are cosmetic compressive symptoms.
okay,
Okay, because this is a long standing. Then how do you explain the weight loss, sudden weight loss?
there was no findings. We couldn't justify that things.
Patient was doing dieting.
No, so diet was normal, sir, but the patient told that he had that weight loss in the last one
No, 10
month.
kg weight loss is very significant, right?
Yes, sir.
Okay, fine. Like you should have examined for that also. For example, like I'll ask you a few questions. Like you have done ultrasound for radiological investigation, right?
Yes, sir.
Do you want to do a CT scan?
Yes, sir, we could do it, sir.
Then why didn't you do? Actually, CT is not necessary.
Okay, sir.
CT is actually not required. Should not do CT scan for a case of thyroid malignancy when you're suspecting thyroid malignancy.
Okay.
The reason being, whenever you do a CT scan, you do give contrast, right? The most often the contrasts are iodine based.
Okay.
So after surgery, you might require radioiodine therapy. So if for
Okay.
radioiodine therapy, you have to keep the patient iodine hungry, so that for the patient should be deprived of iodine for
Okay,
almost
sir.
3 weeks, so that the TSH will be high. So whenever you give a radioiodine, the remaining thyroid tissue will take that iodine. So if you give contrast CT before do contrast CT, so you are already supplying iodine. So you don't want to do that. But there are certain indications where you do CECT, like if the disease is extensive. So it's a huge thyroid lesion with multiple nodes, suspecting your berry sign positive, like if your carotid is in whether the vessels in the neck are involved, you're suspecting all those things. Then you do a CT scan to plan the surgery.
Okay.
So that is the only indication for CECT neck in case of thyroid. So usually ultrasound is sufficient.
Okay.
Okay. So what did you do? You said something unexpected happened, right?
Yes, sir. Actually, they diagnosed it initially as solitary nodule, sir, but after the ultrasound report, they confirmed it as a multinodular goiters.
Okay. Surgery was done for this case?
Yes, sir. It was completed.
Okay. Yeah. So what are the different types of thyroidectomies?
There is a total thyroidectomy, sir, and
Okay.
hemithyroidectomy. Hemithyroidectomy is like a lobe. It's also called as a lobectomy, sir. It involves a lobe as well as the
Oh,
isthmus, sir.
hemithyroidectomy is different from lobectomy.
Okay,
Lobectomy is
sir.
you remove the lobe of thyroid, right?
Yes, sir.
Hemithyroidectomy is you remove lobe and also isthmus and a part of opposite lobe. That is
Okay, sir. Okay.
hemithyroidectomy.
Okay, sir.
Why do we do that? There is no lobectomy in thyroid. You
Okay,
either
sir.
do hemithyroidectomy or total thyroidectomy.
Okay, sir. Okay.
Why? Do you know that reason?
No, sir.
See, there are the junction between isthmus and the
Yes.
thyroid lobe. That is the crucial area where these nodules occur.
Okay, sir.
So whenever you're doing a thyroidectomy, hemithyroidectomy, you should always remove that junctional cells between
Okay,
the
sir.
lobe and the isthmus. So that is the reason why you remove that side lobe, isthmus, and opposite junctional cells also.
Okay, sir.
So lobectomy and hemithyroidectomy are completely different, and nobody does lobectomy.
Okay, sir.
So,
Any other
so
reason why complete thyroid should not be removed? Any other glands in thyroid? Any other glands in the thyroid on the posterior aspect?
Parathyroid glands, sir.
Good, good.
so what is the blood supply for parathyroids?
Um, it is superior.
What is the blood supply for superior parathyroids, and what is the blood supply for inferior parathyroids?
Mm, I'm not sure, sir.
Yeah. So this was actually a trick question. All parathyroids are supplied by inferior thyroid artery.
Okay.
He asked you what is the blood supply individually. Just say all parathyroids are supplied by inferior thyroid artery.
Okay.
During my MBBS, they used to say that you ligate superior thyroid artery close to the thyroid gland, inferior thyroid artery away from thyroid gland.
Okay.
So they wanted to preserve recurrent laryngeal node at that period of time. That is the reason why they used to say that.
Okay.
But later they found out, no, you should always identify recurrent laryngeal node. when like the older teachings are, don't dissect recurrent laryngeal now. If you dissect it, you might injure. That was the older saying.
Okay, sir.
So during my PG, they
Okay.
said no, ligate both arteries away from thyroid gland so that you won't leave the thyroid tissue back like malignant tissue.
Okay, sir.
During my super specialty, they said only ligate superior thyroid artery, don't ligate inferior thyroid artery.
Okay.
Reason is if you ligate inferior thyroid artery, all parathyroids will be necrosed. You don't want
Yes,
that.
sir. Okay, sir.
So always ligate superior thyroid pedicle, inferior thyroid artery. You buzz the branches of inferior thyroid artery supplying the thyroid gland.
Okay, sir. Okay.
Don't have to ligate. These are very small vessels. So you should preserve inferior thyroid artery.
Okay, sir.
That is the latest teaching. You should
Okay.
always dissect recurrent laryngeal nerve.
Okay.
What happens if you injure recurrent laryngeal nerve?
They can be the vocal cords become flaccid, sir, and it becomes an emergency to do a tracheostomy, sir.
If you injure on both sides, okay, not single side, the patient will have hoarseness of voice.
Okay.
Okay, so before surgery,
Yes.
you said that you do ENT examination, right?
Yes, sir.
You have to do for
Yes.
vocal cord mobility to check vocal cord mobility. Why do we do that?
In future, we could avoid medico-legal cases in
Yeah,
case if the patient.
yes, that we should do. Sometimes what happens is patient will have normal voice,
Yes.
but the normal voice is because of the compensation of opposite cord.
Okay.
So yeah, once we do surgery, what happens is because of traction injury or some inflammatory changes, the opposite nerve might have temporary paralysis. So that might lead to tracheostomy.
Okay.
So that for that reason, you should always do a ENT examination for vocal cord mobility.
Okay.
Okay. For example, if it turns out to be uh, papillary carcinoma thyroid, what do you do?
Sir, could you please repeat?
If the final histopathology, you have done
Yes,
a
sir.
total thyroidectomy, right? So you have done a
Yes.
total thyroidectomy,
Yes, sir.
and the final histopathology came out to be papillary carcinoma thyroid.
Okay, sir.
So what is your plan of action?
Uh,
Don't worry, I'll just tell
yes.
you. So for
Yes.
example, see, what are the most common malignancy in thyroid?
Papillary carcinoma thyroid, sir.
See, broad classification of thyroid cancers is two. One is differentiated,
And
the other is
undifferentiated, sir.
undifferentiated tumors. So differentiated tumors are papillary, follicular,
Yes, sir.
papillary and follicular. The other variant is medullary, which is a separate category,
Yes.
and anaplastic is undifferentiated.
Yes.
Anaplastic is the worst prognosis.
Yes.
So their survival rate is very less, and the patient eventually die. There is no
Yes.
person who is living with anaplastic carcinoma. It's a very, very bad tumor to happen. For papillary carcinomas, they carry the best prognosis.
Okay.
So they actually do very well with a normal life. Nobody dies of papillary carcinoma.
Okay.
So usually the most common lesion is papillary carcinoma.
Okay.
So there are certain you have you read about the classification of the papillary carcinoma?
No, sir. No.
Thyroid cancers TNM classification.
No, sir. No.
See, TNM classification. If you see, if you have book also, you can with the audience. If you have book, check the TNM classification. There are
Yes, sir.
certain unusual things that you see in TNM classification for thyroid cancers. They include age in
Okay, sir.
TNM
Okay.
classification, which you don't find in any other cancer. So
Okay, sir.
people who are having less than 55 years, earlier it was 45, now they changed to 55 years, the latest 8th edition TNM.
Okay.
So Less than 55 carry very good prognosis. More than 55, they carry little bit poorer prognosis.
Yes.
Irrespective of size, irrespective of nodal status, if the tumor is the histology is anaplastic, it is stage 4 cancer.
Okay.
So usually TNM is size, nodal status, and metastatic disease, right?
Yes, sir.
For thyroid cancers, if it is anaplastic, whatever the size may be, whatever the nodal status may be, whatever the metastatic stage may be,
Okay.
it is stage 4 only.
Okay.
Okay, these are the important things. And men, the gender is also very important in case of thyroid cancers.
Okay.
Females carry excellent prognosis, whereas men carry poor prognosis.
Yes.
That is an also important factor. But most common gender that is involved in case of thyroid cancers is females.
Females.
Females are most commonly affected, but they carry very good prognosis. Are very less affected, but they carry poor prognosis. So
Yes.
if a man presents with a thyroid lesion, always plan for an extensive surgery.
Okay.
They usually have extra nodal extension, extra capsular extension, all those things. That's a bad thing actually for men.
Okay.
So you have done a total thyroidectomy for this. She is a lady, right? This
Yes,
patient.
sir. Yes.
So you have done a total thyroidectomy, and post-operatively,
Yes.
what we practice in oncologists, we don't because you have done remove total thyroid gland.
Yes, sir.
We don't actually supplement thyroxine to those patients post-operatively, even though we have done total thyroid.
Okay, sir. Okay.
The reason being, we want the TSH to be high. So the recommended TSH in textbook is 40, but usually we wait till 80 TSH.
Okay.
So it usually happens with almost for 3 weeks we stop thyroxine, so the TSH will be more than 80. So
Okay.
after the TSH, we based on the this histopathology report, there is certain criteria called ATA guidelines, ATA, American Thyroid Association risk stratification. So
Okay.
whether this patient comes under low risk, intermediate risk, high risk, which is too much not necessary for you, but I'm just telling you.
Okay.
If the patient comes under intermediate or high risk, the patient has to receive radioactive iodine ablation. So
Okay.
we don't want to have not even a cell in your body, thyroid cell. You have to destroy every thyroid cell in the body. That is the
Oh,
idea. So you
okay.
give radioactive iodine to the patient. So when you give that radioactive iodine, even the small, because the TSH is so high, the thyroid body is so hungry of iodine. So all the iodine will be taken by these thyroid cells.
Okay, sir. Okay.
So then those thyroid cells emit radiation and kill the thyroid tissue. This is what
Okay.
happens. After that, we give thyroid suppressive dose,
Okay,
TSH
sir.
suppressive dose. TSH suppressive dose means actually the TSH, high TSH value will actually is a supportive factor for papillary carcinoma recurrence.
Okay, sir.
So we don't want the TSH to be high. So usually we suppress the TSH. We usually give 150 micrograms of thyroxine to the patient so that the TSH value should be less than 0.1. We want that.
Okay, sir. Okay.
Okay. So this is what happens generally.
Okay.
Do you want to? Do you know anything about follicular carcinoma?
No, sir.
That is the second most common cancer
Okay,
in
sir.
thyroid after papillary. The problem with follicular carcinoma is when you do an FNAC,
Yeah. Yes,
all
sir.
you
Yes.
see is follicles.
Yes, sir.
So follicles, those actually the pathologist will not be able to identify whether those follicles are malignancy or not. They simply
Yes.
give us follicular neoplasm.
Okay, sir. Okay.
So when they say follicular neoplasm, then there will be a dilemma. It could be benign or malignant.
Management. Yes.
So I told you, right? Female, there are
Yes, sir.
age. You should consider all those things.
Okay.
So whenever so the plan should always be a hemithyroidectomy. You should
Okay.
send for histopathology, wait for the report. If it turns out to be malignant, then you have to plan for completion thyroidectomy.
Okay.
Completion thyroidectomy is removing the remaining thyroid tissue.
Okay.
Why can't you actually tell it is benign or malignant in FNAC? Is because in FNAC you can't actually tell the capsular or vascular invasion.
Yes, sir.
Those are cells, right?
Yes, sir.
So
Yes.
only in biopsy you can tell that there is an invasion or not.
Yes, sir.
So in those things, then only we can identify it is malignancy or not. So what in general practice, what we do is we do the hemithyrectomy, send for frozen section biopsy.
Okay, sir. Okay.
So frozen section biopsy will tell the diagnosis within 20 minutes. So based on that, we actually plan surgery. But
Okay.
frozen section biopsy based surgery is not accurate. It is only
Okay.
80% of times it is correct. 20% of time the final report might be negative. So if the
Okay.
patient is ready for a second surgery, you should always wait for conventional biopsy, then plan for completion thyroidectomy.
Okay, sir.
Okay.
Yes.
Do you have any doubts?
No, sir.
Any doubts from audience, please? Okay, then you wrap up.
Can we end the session, sir?
Yes. If
Okay.
everything is done. Yeah.
Yes, sir. We'll end the session with the Shanti Mantra. Sarve bhavantu sukhinaha, sarve santu niramaya, sarve bhadrani pashyanti, ma kaschit dukkha bhagavet. Om Shanti Shanti Shanti. Thank you, sir.
Thank you.
Dr. Devika,
Sir,
what was the hurry in closing?
sorry, sir. Did you have questions?
There are a lot of questions for many people. Dr. Harish, thank you. And it was a real pleasure because I know you were driving the whole way, but still you could.
No, I'm not driving, sir. I'm in parking place actually.
2 గంటల నుంచి పక్కన కూర్చున్నారా?
కార్లో కూర్చున్నాను సార్.
అయ్యో, థ్యాంక్ యూ సో మచ్. ఇట్ ఇస్ సో రిఫ్రెషింగ్. ఇలా కానీ ఒక 1 year కానీ మనం కానీ ఈ ప్రోగ్రామ్ చేస్తే ఐ థింక్ కాంపస్ విల్ బికమ్ ఆన్ పార్ విత్ ఎయిమ్స్ ఆర్ థింగ్స్ ఆఫ్ దట్ సార్ట్. I don't know if the UGs have appreciated the quality of the discussions, but this is a beautiful, too good discussion, and I have to appreciate Tilak because he also has done a wonderful preparation. కాకపోతే ఎంత ప్రిపేర్ అయితే ఏమవుద్దంటే క్వశ్చన్స్ ఎక్కువ అడుగుతారు, దొరికిపోతాం. అది we want to see this kind of outputs only, and that is the reason we have requested quite a few consultants across the state or across the states and across the country to take it out on us. This is exactly what we're looking at. This is only 10 to 20% of the actual questions asked in the exams. ఒక సరైన ఎగ్జామ్ పడితే ఇంతే ఉంటుంది కదా డాక్టర్ గారండి?
Sir, actually, I'm very happy that in UG lo I never had this opportunity to present cases. So, and also I'm happy that too many, like there are good amount of participants actually who are actually participating. So this is a nice session actually. I wanted to ఇంకా నేను డీటెయిల్ గా ఎక్స్ప్లెయిన్ చేస్తే మరీ ఎక్కువ అయిపోతుందని ఆలోచిస్తున్నాను. But
next time what we are thinking is we wanted to extend it a bit more, and at the same time moderator ni kuda if they want to make a presentation they can do it at the UG level.
Yeah, sir. నేను అదే ఆలోచించాను సార్. I'm going too much అనిపించింది. But at least for UG's clinical presentation, the Tilak has done very good job. Excellent job actually. When I was in UG, నేను ఇలా ప్రెజెంట్ చేసి ఉండకపోయేవాడినేమో. But still,
when I was UG థైరాయిడ్ అంటే కాలు పట్టుకునేవాళ్ళం మనం. Meenakshi, yes, Amma, Dr. Meenakshi, where are you? Can you switch on your
Sir, I'm from ACSR Nellore, sir.
Okay, ఏ year అమ్మా నువ్వు?
Sir, final year, 4th year, sir. Just entered from 21 batch.
Okay, then nice. She wanted a good description, like sir said. Probably next time we will try to incorporate that also, Amma. Okay?
Thank you, sir. Thank
Yeah.
you, sir.
Thank you, Dr. Harish. Thank you so much, Andy. I thought you were driving somewhere, or I thought you were, I don't know.
No, sir, I was sitting in the parking space, sir, actually.
You are sitting in the car for 1.5 hours. So nice of you and so
I
kind.
have a small daughter. She won't let me have a discussion because that's the reason why I'm sat here.
Okay, thank you, Dr. Garu. I think we will close the session for today.
Yeah, thank you, sir.
Dr. Meenakshi, please call me once.
Sir, one more
Sir?
thing, sir. I really thank the NMO for giving this opportunity for me, sir. And Harish, sir, I'm really thankful for you. You have gave us so many inputs for me, sir. It was like a huge some information, sir. Yes.
Welcome. Don't feel like actually నేను చాలా questions అడిగాను, you didn't answer and feel అవ్వద్దు. Those all questions are actually for only to educate you.
Yes, sir.
You have
Yes,
done
sir.
a good
Yes,
job.
sir. Yes, sir.
Okay?
Yes, sir.
Yeah,
Yes. Yes, sir. Thank you so much, sir. Thank you.
yeah, you have done a good job. Thank you.
Yes, sir.
One thing which we tell all the students is when we ask questions, it is not to put them down, but to bring the best out of them. అదొక్కటి మీరు గుర్తుపెట్టుకోవాలి. Tilak, you've done a wonderful job, Nana. Excellent job. Great.
Yes, thank you so much, sir. Thank you.
Dr. Devika, please close the session.
Yes, sir.